Our goals tonight are to understand, to prevent, and to help. So to demystify adolescent psychological development, to learn to identify the signs of depression, and how to use resources to prevent and to support and intervene effectively with youth experiencing psychological distress. So let's start with what makes child psychiatry different. So if we compare child psychiatry with adult psychiatry, we have to talk about the important role of the environment. So the younger the child is, the more it is important. So especially with parents, even in older children. So maybe I can say something about that. If you have a child or a teenager who is suicidal, is there a difference as compared to an adult who would become suicidal? Personally, I don't think so, because if you are in crisis, if you are suicidal, you need to have some relatives around you to get some support. So even at the adult program, we ask the patients to provide a phone number from one of the relatives to be able to call them if there is an emergency. So it would be the same thing for younger kids or even teenagers, even if they are 14 or older, because usually with confidentiality issues, we're not supposed to share information with the doctors, with the professionals, but when it's a matter of suicidality, I would invite you to open a little, because the protectors are also the family members. So it's also a non-continuous process involving different domains. So if we talk about the development into teenagers, we know that parents often worried or are confused by change in their teenagers. So each teenager is an individual with a unique personality and special interests, likes and dislikes. However, there are also numerous developmental issues that everyone faces during the adolescent years. So at the end of your document, you can find the facts for families. So we talk about normal adolescent development, part 1 and 2. And they talk about the different developmental phases into middle school and early high school years, into higher age school years. So if I can see, for example, they may struggle with sense of identity. You can see feeling awkward or strange about oneself and one's body. So you may see that into the normal adolescent. Interests and clothing style influenced by peer group. Moodiness. So if we talk about depression or sadness, a normal teenager may feel moody. You may see improved ability to use speech to express oneself, which is not always true of teenagers. Usually they feel that the parents are not perfect and they identify themselves on their parents' faults. They are less overt to affection shown to parents, with occasional rudeness. So sometimes it's also a symptom of depression, so it's hard to make a distinction between both situations. Complaints that parents interfere with independence. So when do we intervene? Because teenagers don't like to have their parents on their back. Tendency to return to childish behavior, particularly when stressed. So when you go through a stressor, they may become more childish, so we don't know if it's something maladaptive or if it's something normal. Teenagers mostly interested in present with limited thoughts of the future. They may have intellectual interest expand and gain in importance. They have a greater ability to do work usually. So we always talk about normal teenagers. They talk about sexuality. So display shyness, blushing when we talk about sexuality. Girls develop physically sooner than boys, so we need to take this into account. They have increased interest in sex. They have concerns regarding physical and sexual attractiveness to others, and they have frequently changing in their relationships. They worries about being normal. So all of those information are in the facts for families, and I think it's very important because when you will look at somebody who is in depression, it's hard to make the difference, okay? And a lot of parents, especially who have been through a suicide, always have the same question. I thought it was adolescent turmoil. I thought it was teen angst. I didn't know that it was about depression. So I think we need to take this and to go through the presentation with this in mind. You also have about the same thing for older adolescents, so almost adult. And then you have an increase in independent functioning, firmer and more cohesive sense of identity. They have better ability to think ideas through. The conflict with parents begins to decrease. So you see with time it's getting better, and you go through from adolescent or early adolescence to adulthood. So they also have feelings of love and passion, development of more serious relationships, firmer sense of sexual identity, increased capacity for tender and sensual love, greater capacity for setting goals, and if we can say capacity to use insight, increased emphasis on personal dignity and self-esteem, and by the end, social and cultural traditions regain some of their previous importance. So now we have the normal teenagers. Let's give an example. If you have somebody who goes from the end of elementary school to the beginning of secondary school or high school, usually it takes what? 2, 3, 4 weeks to get adjusted to the new school environment, school building, new teachers, maybe more for some teenagers, maybe less for those who are more social. So again, we need to think about the developmental aspect to decide whether it's more about depression or just a normal reaction, okay? The other point is about the essential steps for a better understanding of the symptoms. So is it a reaction that would be considered as normal, maladaptive, or is there any severe functional impairment? So it's going to be very important all through the conference to keep this in mind, because it has a lot in terms of dysfunctional aspects. Okay, so if we go from normality to dysfunction, the great dilemma of child psychiatry is always the same. So you want to avoid stigmatization, but at the same time, if you don't get the diagnosis, probably you won't get treatment for the problem, for the disorder. So you want to minimizing handicap, deficit, or pathology. So if we say somebody has an adjustment disorder, it used to be burnout or something like that. It's more or less well accepted. But if you want to get treatment, nobody is aware of that situation. If we are talking now about the same situation and we qualify it as a major depressive episode, moderate intensity, then of course the physician or the professionals around the person will try to provide treatment, to provide probably medication or asking for more information. So you see, it's always the balance between you want to help, but you don't want to hurt the person. Another point that is very important, it's about the prevention. So more and more what we see in our clinic is somebody coming at the very beginning of the mild symptoms, sadness, there's some difficulties, but the boy or the girl is going to say, oh, you know, in my family there are plenty of people with depression. My grandmother had a depression. My uncle had a suicidal crisis at some point. I have a cousin who had killed himself. So can you help me to make sure that I don't have a depression? And if I have a depression, what can I do? So in terms of prevention, you may get treatment earlier if we know about it and to get a better treatment. It's also very important because if you get treatment at the very beginning of the first symptoms, probably it's not going to be a chronic disease as difficult as if you are treated very young. Again, some people may experience more than one episode because it's a long-term problem, a long-term illness, but probably with fewer consequences if you get treatment earlier. So here, depression, is it a non-specific clinical picture? So one side you have something that is normal. So maybe the symptoms are more a maladaptive reaction to a stressful situation. So the child's capacities are overwhelmed. Or it's a message transmitted to the family environment that they have to compensate for the child's temporary incapacity. On the other side, you have something like when there's no adverse event reported or otherwise symptom disproportion. So you have something, but it's too much, there is a sign that you have to do something. Or if you already had some treatment, there is an absence of response to the interventions. Or you may have also some very specific symptoms, so suicidality, retardation, incapacity to keep concentrating in school. So then you may have some consequences of the sadness and the clinical picture. Okay, so what do we know about the beginning of the different disorders in childhood? So the age of onset, and this comes from a very recent paper in the literature. So the mean age of onset in childhood for anxiety disorders is around 6 years old. Then you have the behavioral disorders, like oppositional defiant disorders, those who are not very polite with their teachers, a bit rebellious. So then it's around the age of 11. You also have the mood disorders, and usually it comes with puberty. So if we are around the age of 12, 13, so the mean age of onset is around 13, and 13 means around Sec 1, Sec 2, beginning of high school. You also have the substance disorders, and as we may expect, it's a bit later, so it's around the age of 15, but still 15 is very young if we think about somebody who's using on a regular basis some substances. Okay, so let's say anxiety disorders. What kind of anxiety can we see in this group age? We have the separation anxiety disorders. We may have generalized anxiety disorders. We have a lot of phobias, spies, the bridges, the elevators, or the darkness. We also have those that would come in between anxiety disorders and behavioral disorders with ADHD, so attention deficit disorders or hyperactivity disorders, impulsivity. So they would come in between. And then here in the mood disorders, you may see depression, depressive disorders, but we can also see dysthymia, which is a minor form of depression, and I'm going to talk about this in a minute. At this point, it's usually the unipolar, so meaning more depressed poles, but you may have at some point, after the substance disorders, a bit later on, psychosis, bipolar disorders, and also part of it, you may have social phobia, so feeling very shy in front of people, new people, or being at school. So a lot of people, a lot of teenagers have more than one disorder at a time. So you see, a lot of teenagers may even experience 4 of them. So it happens. So that's why we need to be very clear about what is it, what type of disorders we have, what kind of treatment should we target first, and then is it going to affect the improvement in the other disorders. Okay. So adolescent depression is not rare. It seems that over the past 10, 15 years, depression has increased into our society. We don't know yet why, we don't know the specific reasons for that, but really it has increased. It seems that, well, first let's say, usually you have equally boys and girls with depression before puberty. But as soon as you enter into puberty, you may have 2 to 3 times higher rates of depression in girls and boys. So you see, there is something about girls. Some people have said it's about hormonal components because, of course, there's a puberty, so they have their first period. But at the same time, there's some psychosocial stressors, pressures onto girls. So maybe it's about the role of the women in our society. But again, there are probably many reasons to explain that. Is it about the divorce, the high rate of divorce? Is it about chemical, something into our, environment that may contribute. At some point I thought it was a bit funny, but not anymore, because we are, we have to be in touch with so many different things in our world currently that I think it could be another possibility. So depression runs in families. So for sure, you'll see in a minute the prevalences, but of course, if you have some people into your biological family, you're probably more at risk. So there is maybe something important. So a lot of people, everybody can have a depression, okay? But some people may have some vulnerabilities, some biological vulnerabilities at baseline. So two people, one with the vulnerability and the other one doesn't have the vulnerability. But if they go through a traumatic experience, like a life stressor, life events, then they may develop a depression. Of course, the person who is already very vulnerable may be at higher risk than the other person. But again, it depends, everybody is different. But it helped to explain why some families are more at risk than others. So adolescent depression can lead to different consequences. So you have academic and social impairment. Somebody who's very good at school, very performant, if he goes through a depression, may fail even his school year, may have to change the options that they have for the future, not getting accepted to something very competitive, and it's all about a depression that was not treated. You may have, for other people, just school dropout. So some, teenagers are not that, it's not easy for them to go to school, to attend schooling, and then with the depression, it's just what was missing to stop going to school. You also have self-injury. So a lot of teenagers, and we'll see this also in the next slides, who will cut themselves. It can be part of different problems, but of course depression might be one of them. Self-medication. So a lot of teenagers may say, well, I use alcohol to decrease my anxiety, I'm not feeling well. So it can be related to anxiety, but it can also be related to depression. And sometimes they feel better, but it's like a vicious circle, so they are not getting better on the long run. You can also have an increased risk for depression in adulthood. So of course, if you have depression at a young age, you're more at risk to develop another episode later on. And suicide, I think suicide is very important to share here, because if you look at the 15 to 19 years old age range, the first cause of death is about car or motor vehicle accident. The second cause of death is about suicide. And the third one is about tumors. So usually brain or the nervous system pathologies are about for those who have died as a third cause of death. So in the past years, suicide was the first cause of death. So it's better than it was, but it's still the second cause, which is too high. In the 10 to 14, it's a bit different but similar. So still first cause of death, accident. The second one is the brain tumors and blood tumors, leukemia. And the third one is suicide. Usually in 10 to 14, the first suicides are not at 10 or 11, it's usually around 12. So again, it's all about puberty. So there is something about the hormonal and the social aspects of it, okay? So we need to work all together to decrease the suicide rate. Okay, so what is the rate of depression, major depression? So in children, it's usually 2%, and as I mentioned, it's equally, frequent in both boys and girls. With teenage years, so around 12, 13, usually it's 4 to 8%, but it's higher in girls than boys. And according to some papers in Toronto over the past year, they said that it has tripled over the past year, especially in girls from 12 to 15, and they don't know why. Into adulthood, again, women are at a higher risk than men, and the lifetime prevalence is around 20%. If we consider only symptoms of depression, without the clinical significant distress that is usually required to have a diagnosis of major depression, it may get higher, around 28% into the population. So it's quite frequent, and you may meet a teenager with depressive symptoms. So what is interesting, 50% of the adults have reported that their first episode was before the age of 20. So retrospectively, they were able to say that they had their first episode before the age of 20, but not necessarily got treatment for that episode. Dysthymia, as I mentioned, is a minor depression. It's usually fewer symptoms, but still sadness or irritability, and it has to be for a period of at least 1 year in those below the age of 18, and in adults it's usually 2 years of those minor symptoms, okay? But what we know is the risk to have a major depression is present in 70% of those patients. There's also some literature about a link between attention deficit disorder, maybe dysthymia, so minor symptoms of depression, low self-esteem, feeling sad, not very competent, and a potential bipolar disorder later on. So again, it's hard because usually when I was a resident, usually bipolar disorder were we could say that around the age of 30-ish. And now more and more we've decreased the age, and usually now it's more in our clinical work, it's more about 16, 17 years old. Okay, in the States, they report very young children with bipolar disorders, but it's still a controversy. Okay, if we want to go to the differential diagnosis, I think it's very important, but at the same time, I've already talked about the risk of making this type of diagnosis. So we'll go through all of them. So the general medical condition, the effects of a substance, if it's a transitory or adaptive period of their life, normal bereavement or complicated bereavement, the different major disorders in terms of mood disorders, and if it's depression secondary to another major psychiatric diagnosis. So if we talk about general medical condition, a lot of people feel that, maybe not anymore recently, but before, let's say it, that we ask for a consultation from a general practitioner instead of being able to go directly to the psychiatrist. There are reasons for that. It's because we need to rule out a medical condition, a general medical condition. It's quite important because a lot of infection, for example, the mononucleosis, may bring with it some fatigue. And fatigue is one of the main symptoms into depression. So if you go through a very important infection and you don't get the diagnosis, we may feel that it's a depression. And it's not the same thing. Okay? So if you have problems with your thyroid, it's a gland that we have into the neck, so if it's not well balanced, of course you may experience some fatigue, loss of energy, feeling down, and it's all part of another disorder that is a medical condition, and you can get treatment for that condition. Another example, brain tumor. Brain tumor, if you get treatment for depression and you have a brain tumor, 6 months later, it's not very, positive in terms of outcome. So of course you want to get treatment very quickly for a cancer. So that's why psychiatrists are usually good to assess a medical condition, in terms of psychiatric disorders, but to make all the physical examination testings, it's better if it's your physician, your, practitioner or pediatrician if you are a young person. So there are plenty of conditions that may mimic a depression, so it's very important to get a good blood test, workup, and your physician is probably the best person to perform that. Physiological effects of a substance. It's also very important because even if they don't share with their parents, teenagers used to take substances. Are you surprised? We are sometimes. When we talk to the teenagers and we ask how many, joints of cannabis do you use per week? It's like we have sometimes 3 joints per day. So if you take a lot of cannabis, and more we know that it may bring psychosis, especially if it's before the age of 16, you may see all the different damages that it makes to your brain. So cannabis, weed, pot, they may say something like that. Ecstasy and speed, amphetamine, usually it looks like more a manic episode. So you're very high, or you have a down right after because there are different reactions into your body. So please don't be too naive. Try to find a way to ask the question in a not judgmental way to get a lot of information because it has an impact on the brain and on the mood. Okay? But I can tell you we have a lot of surprise sometimes. Okay. What about a differential diagnosis in terms of transitory or adaptive disorders? So is it normal sadness, anger? Is it teenage turmoil, as I mentioned at the beginning of the presentation today? Is it adjustment disorder with sad mood? So it's another diagnosis into the DSM. The DSM is the dictionary for psychiatrists. You can have adjustment disorder with sad, anxious mood. And you also have adjustment disorder with mixed disturbance of emotions and conduct. So they all look about the same with different, tiny differences. But it's all about feeling sad when you have gone through a life event. Abortion, for example, for a teenager who's not necessarily in relationship with her parents because they don't want to share. You may have just family discord. Very severe family discord is also a trigger. You may have a divorce. You may have a breakup with a boyfriend, with a girlfriend. You may have a failure, to fail an exam, a very important exam. So a lot of situations may happen, and usually if it's getting better over the weeks after the trigger, so we don't call it necessarily a depression. We call adjustment disorder. Okay, and it's extremely frequent into the emergency rooms to see the diagnosis of adjustment disorder. Okay, normal bereavement versus complicated bereavement. So I've tried to find some explanation because I think it's easy to understand, but sometimes what would make it like a depression versus a grief? So, of course, it's a reaction to the death of a loved one. But as part of the reaction to the loss, some grieving individuals present some symptoms that are characteristic of major depression. So they have feeling of sadness, they're missing the loved person, they may have insomnia, it's quite frequent, they would cry a lot, a poor appetite. So usually it takes time to get better. But when it continues over time to be very severe, then we may consider that it could be a depression. For example, you may have hallucination, hearing the loved one or seeing the person. That is normal. It's part of the grief. But if you start to see other people, or, you can imagine when it goes very wide, then you may question. Or if you have a guilt feeling, of course you may have guilt about something that you wanted to do and you didn't have time to do, or to share some information, some secrets, something like that. But when it's about everything, then it's time to get help, okay? The same thing for the young, very young ones. You need to be careful because sometimes they don't understand the concept of death, so they're not yet there. So it's usually more with teenagers that we will go to the more abstract thinking. So sometimes they want to join the person who had died. So we need to explain this at their level with their developmental stage, okay? But of course, if it's too long, too severe, and their clinical functioning is very affected, then we may consider that it's a major depression. Okay. If we go to the mood disorders, so we have the major depressive episode. So you're usually down, you have a very severe drop into your mood. You may have also the manic episode, which are high, very distracted, a lot of power, a lot of fun. So it's completely the opposite. You may experience mixed episodes. So you may have during the same day for many days feelings of highs and downs, but on a very quick period of time. And a lot of teenagers have this because their first episode may be mixed like that. And you have dysthymia, as I mentioned, the long-standing minor depression. It can also be secondary to another major psychiatric diagnosis. So usually the most frequent into the community is anxiety disorders. So if you have an anxiety disorder, you're very obsessive, very, you worry all the time and you're concerned about many, many details. With time, you can stay at home, not being able to go to school, not being able to go through the exams, for example, if you're very perfectionist. So then you start to become more depressed and to develop a full-blown depression. There's also eating disorders. A lot of teenagers may experience, changes with their body, with their image. They want to go to a diet, to eat different things. So sometimes it may come together with a major depressive episode as well. Okay, so if we want to prevent the transition from elementary school to high school and from high school to college are risky times for many tweens and teens. So more and more the younger, the tweens they are acting like teenagers. But every time that you have a transition, you need to be very careful. So I have a researcher who told me, don't get divorced when your son is going to go from the 6th grade to Sec 1, because it's a very risky time of their life. It's the same for when you go to CEGEP or university. So you see, you need to, and we do that, if we have a very strong or intensive follow-up in terms of psychotherapy, usually we don't stop until the end of the school years after the exams when everybody is calm. So we have to manage. Of course, if they're getting better, it shouldn't be a period that we have to target, but because it's more stressful. So we just have to be careful in how we treat those teenagers. We have to be on the lookout for signs of depression or bipolar disorder, and don't discontinue therapy or medication when starting a new school year or transition. So what are the depression warning signs? So you have the unusual sadness, irritability, or acting out. This is very important because usually we feel that depression, you are supposed to cry. So some teenagers, especially boys and men in the adulthood, would express more their sadness with irritability, not being nice, very, they're not easy to talk with, or even acting out. So even on the American Academy of Child and Adolescent Psychiatry website, they were talking about rebellious act, running away, acting out. So some teenagers, and it's especially true when you have a change into their behavior. Okay, because if you have somebody who was acting relatively okay, normally, in quote, and then you have a sudden change with irritability, some sadness, and acting out, then you may question if it's a depression. You also have loss of interest in things previously enjoyed, changes in appetite or weight. Usually you have overeating, you may have a decreased appetite. In teenagers, you see oversleeping a lot or major shifts in sleep patterns. Lethargy or decreased energy, so they have no energy, no motivation. So sometimes parents feel, well, it's not that he's depressed, it's not just motivated. So how do we understand the symptoms is very important. Feelings of worthlessness, hopelessness, or guilt. So if you feel guilty for something that is not very accurate, so then you can question again. The diminished academic performance, we've talked about that. There is an increased use of alcohol or drugs. Some teenagers may also have aches and pains with no physical explanation. So sometimes it's more anxiety, but anxiety may be part of a depressive episode. Even in the DSM-5 that is coming next spring, so they wanted to include a new type of depression, which is called the depressed anxious, a depression with a lot of anxiety. because it's probably more difficult to treat somebody with those features than only with depression. You also have to think about the psychotic symptoms that are often hidden. So teenagers would not, report, I hear things, I see things. So you need to find a way to ask the question, which is not easy, okay? When I teach medical students, I say, don't ask it, directly. Please try to say, well, sometimes when you're in your bedroom, do you feel that there's some presence, there's somebody around? How do you feel? Have you heard something? Not necessarily suggesting different things, like did you see somebody working in your bedroom? So it's a bit different, okay? But again, they are very shy because they know that there's something crazy into it, okay? So we need to be very delicate in the way we will ask the question. So what is the difference between adult and adolescent with their symptoms? So if you see here, the depressed mood or loss of interest or pleasure in nearly all activities. So in teenagers, you have the irritability, decrease in appetite or weight. So usually it's overeating, increased weight. Decrease in sleep in adults, increase in sleep. Lethargy or agitation, the same thing for teenagers. Decrease in libido, little sexual impairment. So as I mentioned into the developmental aspects, usually it doesn't affect much because they're at the beginning of, they are very interested by the question. And social environment plays a small role. It's not always true of adults, but into the literature it's how it is presented. And teenagers are very reactive to social environment. So you see it's the main difference into teenagers. So what do we know about the facts in suicide risk? So I mentioned that for depression, you have more girls than boys having a depression. However, when we talk about completed suicide, we have more boys than girls who will take their own life. Why? Because they use more lethal methods. So that's why they are killing themselves more often than in girls. So what do we know? In males, we need to be careful and look at previous suicide attempts because then it increases the risk of a suicide. Age 16 and older is very important because the mean age range was about 16.8 into the study in Quebec. An associated mood disorder, but I just want to show you that for boys, it's the third risk factor, and girls, it's the first one. And associated substance abuse in boys, which is in girls, is less frequent. But I guess with the girls having an increase in their depressive rate, maybe we will see changes over even the suicide rate. So again, mood disorders in females and previous suicide attempts. So the immediate risk predicted by agitation and major depression. Because if you have somebody who's very depressed, but at the same time irritable, aggressive, nervous, he may act out on the feelings of sadness on a Friday night, a Saturday night. If they get a call that is not very positive, then they may have a higher impulsivity and may take their own life. So we need to be very careful. Okay, so a rigorous assessment evaluation is essential. Present or absent parents are always there. So if you talk to a teenager again, you will receive some information. That's great. We need to have a good alliance, a good contact with the teenager. But we need to have other people to validate the information. So we would like to have parents maybe separated if they are not together, because we want to have their own point of view. Because if they live in a different environment, maybe they see other symptoms. If they live together, we would like to see if they are in the same position. And if we may have the grandparents or another person, that would be very interesting. You may want to have the teacher's advice or the after-school program person who is the professional who is involved. Sometimes they want to bring a friend. So we try to see and to make contact with the teenager, the parents, but with time we may want to see the boyfriend or girlfriend to have a better understanding of the situation. Because everybody has the piece of the puzzle, and together maybe we will be better, okay? However, the psychological assessment can help, but not necessarily will, confirm all the time the diagnosis. But of course, it's going to help in terms of personality issues, traits, ways of coping. If there is impulsivity there, something, or learning difficulties, of course, it may help. You can also look at the clinical course that will help to clarify the diagnosis, because sometimes in child psychiatry and adolescent psychiatry, it takes time to have a clear picture of the situation, because they are still changing over time, and it's not like in the adults. We don't want to stigmatize, we don't want to avoid the treatment, but at the same time, we don't want to make a mistake. So that's why the clinical course is very helpful. Okay, so you want to go back to the developmental history, so the temperament of the teenager, if there was some separation anxiety, cyclothymia, if there was some impulsivity, ADHD, everything that you can get is a very important part of the assessment. You want to look at the family history. It's very important to me. So if there is a history of major depression, bipolar disorder, suicide completion, suicide attempts, any suicidal gestures or ideations into the relatives, alcohol or substance problems, we want to have a good picture. We want to identify the psychotic symptoms, suicidal risk assessment, history of a prior suicide attempt. And if we talk about suicide attempters, we have more girls than boys who would overdose or use some substances, but probably will get some treatment or some help, calling a friend. Facebook is also very much involved into those things. So girls tend to have more suicide attempts than boys. There's also impaired functioning and precipitating factors. If there is a violence history of violence or abuse meaning sexual abuse, childhood abuse, physical neglect, it's all very important because it may have impact even later on their life. And the availability of means. So a lot of families, even if we're not supposed to have firearms or guns at home, they do have some. So if somebody is going through a major depressive episode and there is access to the firearms at home, you need to remove the guns or the firearms. It's very important, at least for 2 years. Because sometimes people say, oh, we've just removed it for 6 months, but you need to be very careful. Also the pills. When the physicians prescribe medications, sometimes they want to prescribe for a long period of time. But you need to be careful because it's, again, when you're very impulsive, not feeling well on Friday night, if you have access to like 100 pills and you take a lot of them, it's already a higher risk in terms of overdose. Okay, so you can also have other problems, as I mentioned, so ADHD, oppositional defiant disorders, learning disorders, all the anxiety disorders, the Tourette syndrome, for those who are not familiar, is those with tics. You may also have a potential situation of sexual or physical abuse at home or in the neighborhood, so you may have, depressive symptoms, but if you are going through a difficult relationship with somebody who is abusive, of course, it looks like a depression. So you won't treat it the same way. And you may have a physical illness. Okay, so as many as 1 out of 14 self-injures. So cutting is the most common form, and self-harm is extremely addictive. It is addictive. More you cut, more you want to cut. Okay, it's because there is something that is stimulated when you cut, and then it's like an addiction. Okay, so you need to stop this from the beginning. There are 2 main varieties of self-harm. There are some teenagers who are injuring themselves to feel some pain, so they don't have emotions, they feel down, empty, so they want to feel something. And the other group that is more frequent, they want to alleviate the negative emotion. So when they cut, it seems that it changed their state of mind. Okay, but both are very addictive. Treatment. So if we talk about treatment for adolescent depression, it requires synthesizing information from both parents and the teenagers separately to perform a work evaluation of school performance. So you need to see if they are capable of doing their schoolwork as usual or if there is a problem there. The irritable mood has to be considered, and there are indirect evidence suggesting that depression in children and adolescents are influenced by psychosocial variables such as peers and family as well as environment events. And children in particular appear to be more responsive to non-specific treatment. So there is a higher placebo response rate in children and younger teenagers. So sometimes we feel that just supporting is already some help for the teenager. Okay, you don't necessarily have to do a lot, just supportive intervention is already something very positive. Okay, so you may help those teenagers if they have a mild form of depression. We need to have active monitoring with ongoing assessment of clinical status for a few weeks. It's encouraged when this can be safely done, particularly for pre-adolescent. So we talk about psychoeducation, lifestyle management training that may be helpful for this period of their life. Assessment of suicidality, and you need to do this on a regular basis because sometimes they don't have any suicidal ideation, sometimes they have some, and they won't tell you. So you need to reassess on a regular basis. Elements to consider when deciding on medication versus psychotherapy. So it depends on the severity of the clinical picture, suicidality, family members' previous response, the chronicity, or the lack of response to psychotherapy, because maybe you've tried some psychotherapeutic intervention, it hasn't been very effective. You may have the family preferences and the psychosocial stressors. If you remove the stressors, maybe it's going to be better with just support. So that's why supportive, psychodynamic family intervention, psychoeducation may be appropriate in addition to medication depending on the severity of the depression. So evidence suggests that specific psychotherapies such as CBT is cognitive behavioral therapy, IPT interpersonal therapy, and the other types of intervention are effective treatment, at least for mild to moderate depression. Okay, so you should start to begin with some psychotherapeutic intervention, and if it doesn't work, or if it's getting worse, or if it's too much and you feel that there's no good results, then you have to move to medication, and medication plus psychotherapy are the best combined treatment, because medication alone is not that great. So you have psychoeducation, so how you have to sleep on a regular basis, to have some activities just for fun, not always studying, exams, working all the time. And you need to have a life with not too many substances, alcohol, parties, because at some point you won't feel very well. Okay. The decision to initiate medication versus specific psychotherapy is made jointly by the clinician and adequately informed parents or guardians with assent from the child. So again, it's not that easy, because if you have somebody who's a teenager, again, depending on the developmental aspects, you will try to engage the teenager but also the parents, because even if you're 17 or 16, probably you won't go to the pharmacist to get medication if you have medication. So if you haven't shared with your parents, there's going to be a problem between you and your parents. So you need sometimes samples. We can provide samples if somebody doesn't want to share with their parents. But again, it's not going to go very far. And as soon as you have suicidality, you're supposed to engage the parents into the treatment plan. So it's very important. Even, I can say, like grandparents, if they don't want, the teenager wants his grandparents or her grandparents to be involved and not the parents, at some point there's a problem between the different family members, because there are some secrets and confidentiality issues, and it's not that great. So we try to avoid to split too much, but sometimes we have to work with those who are coming. So a treatment plan combining psychotherapy and medication is often very effective. So as I mentioned, the interpersonal therapy, In the States, they talk about the behavioral activation. So it means you have to mobilize a person because they're sleeping all the time on the couch, not feeling well, eating too much, not going to school. So what would you do first? So you have to take a shower, to eat a good breakfast, to exercise a little, and to go to school. So that is called the behavioral activation. You also have the cognitive behavioral therapy. Then you have to be a little bit more focused on different tasks like schoolwork. So some teenagers would not like it too much, so we go with more the behavioral activation. In terms of medication, I won't go through all of them, but of course there are different medications that can be used in teenagers, but we don't have so many options. It's a bit different than in adults, okay? So, sufficient severity to warrant medication. So we need significant psychosocial impairment in family and peer functioning, or school performance, or a risk of harm to self or others. So you see, you need to have enough severe picture to decide to treat with medication. So the SSRIs, for example, you may have the fluoxetine, you may also have the venlafaxine, you have also bupropion, so there are many medications. But you need to be careful. There is the FDA black box warning. I don't know if you're familiar with that. In the States in 2004, and then in Canada and in England, they talked about a higher risk of side effects coming from the use of some medication for depression. So at the time, they were saying that there was an increased risk for suicidal behaviors and suicidal ideations, but no more suicide completion. At some point, they extended it, saying that even until the age of 25, you had a higher risk of those side effects. But in 2012, it's always changing, you see. They said, well, a reanalysis of randomized studies demonstrated that suicidal thoughts and behaviors decreased over time for adults and geriatric patients who had taken fluoxetine or venlafaxine, but there were no differences in youth. So they used to say that there was a higher risk of suicidal ideations and behaviors, but with this new study, they didn't see a great improvement, but there were no higher risk in terms of suicidality. In adults and geriatric patients, they were able to see a reduction into the suicidality. So that makes a difference between teenagers and adults and geriatric patients. So why do we find this? So for youth, no significant effects of treatment on suicidal thoughts were found, although depression responded to treatment. So those who had depression had a better response in terms of their depressive symptoms, so they were less depressed, but still suicidal. And we feel, and that was true only for the fluoxetine, okay, only for the pill that is called fluoxetine. Our understanding is that there is another part into the clinical picture, and it's impulsivity. So we need to be very careful with teenagers because even if they're getting better with their depressed symptoms, they're still impulsive. So that's the part that medication is not that great, and we need psychotherapy and a good parental, to be able to support the teenager who's at risk. Here it's just to say, you see, usually you have all the psychotherapeutic interventions, the non-medication treatment alternatives, and then if you have more depressive symptoms, more or less severe, or ADHD, more or less severe, because you can have both, then you need to decide if you go with the treatment for depression or the treatment for the other condition, and then if it's getting better, you continue, or you will change your treatment. So you need to be very careful in the way you will provide the medication. In conclusion, so we have many types of reactions in depression, sadness. We need to carry out in-depth assessment to stop waiting for problem to go away, to consider concomitant disorders, so you may have more than one disorder at a time, to take conditions seriously given long-term implications, and to early detect for fast, effective intervention appropriate to age of child. You need to detect young people at risk, carefully assess youth in crisis situations or who are withdrawn from usual activities, okay, so the change. You need to work in teams under supervision. Don't do that on your own. It's sometimes very difficult, and you will get nervous and worry, and it's not that helpful. You need a therapeutic alliance with the teenager to ensure follow-up and to integrate family and close relatives in intervention plan and service delivery system. So you have in the references facts for families, the tips for talking with adolescents. Sometimes it's not that easy, so they give you 4 ways to start a new conversation with teenagers. You have the Depression in Children and Adolescent information for parents and educators, the practice parameters for the assessment and treatment of children and adolescents, and the other one is the Texas Consensus Conference Panel on Medication Treatment of Childhood Major Depressive Disorder. So I'd like to say thank you to the adolescents and their families. There is also the Québec Suicide Research Network, Fonds de la Recherche en Santé du Québec. So I'm in charge of the clinical sciences of this group, McGill Group for Suicide Studies, and the mental health team workers, practitioners, and school workers. I think you are very important. Family members, of course, and the Standard Life Center for Breakthroughs in Teen Depression and Suicide Prevention. So thank you very much for your attention.